Welcome to PT Chit Chat.
Welcome back to the vlog. Oh, wait. I mean
Welcome back to the
podcast.
blog.
No, sorry, man.
This is what happens when you take your
Different,
4-month break and you come back
different
to a
project.
podcast.
Different project.
Wait, you're running a blog though?
A vlog? Yeah, I've been having a
Sorry, I
vlog.
said blog.
No,
Man, with a
vlog,
V.
video log.
Yeah.
Yeah. How you been, man?
I'm good, man. How you doing?
I'm good. I'm in a new place. I'm in Alabama.
As you can see there, though.
I got some Crown Apple, some lime juice, some ginger beer.
Did you like to pause in the beginning as I waited for you to introduce us this time? I was like, yeah, I ain't doing it this time. It's not me this time.
It's not you.
Bro, what are we talking about today?
Oh man, I don't know. It's been so long. Let's do something easy. Let's talk
You're
about
telling me we didn't prepare for this?
Do we prepare for any of them? Sometimes.
I try.
Sometimes. Let's talk about something easy. Let's talk about
Easy. There
let's
is
do
no
back pain.
easy in PT.
Let's do back pain. It's
good.
common. It's a common type of injury.
P.S. We talked about this on Wednesday. We're doing back pain, so.
Yeah, let's do some back pain.
Well, before we start, you're in Alabama. What's up?
Yeah, man. New contract. I'm in Alabama. So I'm in my little place right here, as you can see in the background. That's why it's different.
It looks the same to me. It was a different background, but it's all the same. It looks like a solid room, Nico.
Well, thank you.
Yeah, where's Ollie at?
I'm in Birmingham. Ollie.
Where's our guest speaker for?
Ollie is on. He's laying down on the ground. He's sleeping. Yeah, we did some training in the dog park today.
Nice.
Well, outside the dog park, because I want other dogs to be in the area, but I didn't want him. I wanted him to fight those distractions.
So, back pain.
Yeah, man.
Pretty common.
So, how many of your patients would you say have a back problem?
How many of my patients have a back problem?
Like what percentage of your patients?
I would say maybe 10% in my current caseload.
Wow.
Yeah, because like 80% of shoulder issues right now.
Wow.
I don't know what's going on. Yeah.
You know what? Therapy does do that. You have stride. You have at one time you'll have like all these shoulder pains, and then another time it's all back pain.
Honestly, you asked me the same question maybe 2 months ago.
Mm-hmm.
I'd probably say about 50% back pain.
Yeah, man.
And I don't know if that has to do with the winter and snow shoveling and all that business. Could be. Right now, it's all shoulder and younger athletes. So,
nice.
They're at playing.
That's fun to work with.
But yeah, I know you were expecting 90% back.
I know. Yeah, I feel like everybody's
it is, right? Yeah.
Everybody's back hurts all the time.
I mean, my back hurts washing dishes, obviously, but
yeah, man. Honestly, there's so much back problems that I see. Okay, so the back is kind of a tricky. It's kind of a tricky diagnosis, right? Because there's so many different things that you can have in the back.
Yeah. So what can we have? Someone comes in with a back pain. Let's just go through. Maybe let's go through differential diagnosis.
Differential diagnosis. I like that. So if somebody comes back,
let's not talk about like fracture and like bruising and all that stuff.
Right.
Let's forget all that, right.
So let's say we have stenosis.
Right. So narrowing of the spinal canal, right, for whatever reason.
We have disc pathology, like a bulge or whatever.
Disc derangement. Yeah, sure.
The disc derangement. Ooh, disc derangement. That's much better. You can have slipping of the vertebra, so like a spondy, like spondylosis, spondylolisthesis.
I ain't about to say that out. But a spondylitis and spondylolisthesis and
spondylolisthesis, a slipping.
What is that? A Scotty dog?
Yes, that is
Scotty dog.
And then and then there's a ton of muscles there, so you can have all of muscular.
Any kind
muscular
of strain.
Yeah.
Any kind of paraspinal muscular strain.
Yeah. Or that weird one. Like, what was that weird one that you had a few months ago? The QL strain.
Yeah.
That was weird.
That is still weird. I still don't buy it.
That is still weird, man.
Still don't buy it.
That is a crazy.
How do you get a QL strain? I mean,
it's hard. So
QL, where is it attached to, right? It was that
quadratus lumborum.
From the iliac crest to like what, transverse of L3 maybe, something like that.
Something like that, man. That's
It's responsible for hip hiking essentially.
Best believe I don't know the QL like that.
Yeah, I think it's just responsible for like hip hiking, right? And probably adds a little bit of stability, right?
That's the hip hiking muscle.
Yeah, before someone shoots me down.
So
we got muscle strain, stenosis, disc derangements. We can have facet dysfunction, right?
Oh, of course, facet dysfunction, anything with the spine.
Which I don't really see often.
Those are nice quick fixes though. I like facet dysfunction.
I don't really see it often because like
Yeah.
anyways, we can talk about how we kind of differentiate those from one another.
So let's start with the major ones, right? So if a patient comes in, what I look for personally is, first of all, I check their age, right? That's the first thing before I even like listen to their story. You want to know how old they are. Why, Payman?
Well, I don't know what your cutoff is, but like obviously, listen, as we age, this is not to say that it's symptomatic, right? Let's just make this clear. So as we age, obviously the disc deteriorates, right? That fluid inside the disc goes kaput, right? It's just, it is what it is.
It dries out. It
is what it is.
Desiccated
at the end of the day. Word. And so now, will it be symptomatic? Not necessarily. Will it catch up later down the road? Maybe, right? So obviously, when you're thinking about the disc height being reduced, what do we think about like stenosis, right? I mean,
stenosis, yeah. So typically, I believe at the age of 55, your disc starts drying out or desiccated, and so the folks that are older than that age, you typically don't see a disc derangement because, like we said, it's dried out.
Have much of a disc, right? I mean,
yeah, there's not much fluid left in the disc. Now, we're not saying that it's not possible because it absolutely can be, but there's a higher chance that it's something else. So younger than 55, my first train of thought is, oh, it could be a disc pathology. And then older than 55, I'm thinking more something along the lines of like stenosis or something.
And we talked about this, when we were kind of talking on Wednesday, where like I look for mechanism, right?
Yes.
Tell me how you injured yourself. Like, man, what was it? What does this guy say? So older people, right? Generally, the geriatric population. I'll be like, okay. So what did you do, right? And they'll be like, nothing.
I just woke up.
And my question is like, so Friday night, you go to bed, right? And you're good. They go, yeah. And I'm like, so the next day you wake up, you're bad. They go, yeah. So then I'm like, okay, first of all, it didn't happen during your sleep, right? It's not an overnight thing. So then I go, so how long has it been going on for? And they go, a couple of years, right? Or maybe even 5, 6. And then I'm just like, oh, okay. And I go, has it been getting worse, right? They're like, yeah, it's been kind of getting worse. It's on and off. Lately, it's been a little bit more worse, right?
How do they sleep? That's always a good question. The position they sleep in.
Sure. But then I'm just like, so what do you think changed it? And then I think now we're in a lockdown, right? So they're like, oh, I'm not attending my geriatric classes, right? Like those community
silver sneakers.
I don't know what do you call that? The community here, like there's like senior homes and stuff, and they get together, or like they go outside and they do tai chi and all that.
Sure. Yeah, sure.
So they're not as active, right? So then I'm just like, oh, okay, right? And we know when like, if you're not active and you have stenosis, well, that's gonna lead to some stiff back and pain, right? Ultimately. Sometimes they'll complain of like radiating pain. And it's weird, eh? So it's funny because my mind still, I hear radiating pain, I'm like, oh, maybe bulge, right? But it's not necessarily the case, right? It's not the case, likely, right? So so you do your like, I don't know what you like to do, but I'm still.
So let's start, Payman. Let me give you a patient, and we'll talk about kind of
how I kind of go about it.
Yeah,
maybe how you kind of go about it.
So let's get a mid-30s gentleman, and he's complaining of pain that goes in his back, hurts a lot, terrible pain. Ask me questions.
Yeah. So okay, first of all, you all know this. I mean, every PT should know this. Watch how they walk right away, right?
Yes.
Like watch how they walk. Well, watch how they. So they're doing their like papers, right? And I'm like awkwardly staring at them, right? And then I go, "Oh, hi, my name is," right? So I'll wait a little bit.
So what are you looking for when they're walking?
First, I'm just trying to see how they're sitting. Sometimes they like to be bent over. I did this when I was in pain on my right side. I would shift away, right? I shift away from the pain, and
that's what I look for too. I look for that lateral shift.
Yeah. So doesn't necessarily mean they have a shift,
right?
But it may give you an indication of which side is hurting, so you know what to look for as they get up and start walking, right? So they get up and start walking, and when you're looking at their walking, are they, favoring one side to the other? Are they leaning away from that one side? Do you see an antalgic gait, right? And then you can also tell like how big their steps are, right? What's their, stance space? What's their step like? All that stuff. Right. It's funny, but
are we taking small steps because we're hurting, or are we taking normal strides?
Are they leaning forward, right? So with the stooped over posture, the shopping cart sign, I see that a lot with like the geriatric population, right? They'll be like bent over. It just feels better.
It
And I'm
feels
like, I
good.
don't care if it feels better. I am making you straight. We're gonna slowly get there. But anyway, so anyways, I'm watching how they walk. They come in, they sit down,
So
and
before they even talk to you, before you even say hello, guys, you already have information.
yeah.
Already have information.
I mean, that doesn't mean I'm sitting there in my head checkboxing everything, but you kind of
Right.
get
But
at,
it just kind of guides you during your exam, because no two exams should ever be the same, ever, 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 ever.
honestly, I'm like low key super simple. So like, I'm not gonna,
You
I
like
don't
to keep
really
it
like,
simple, stupid.
I don't like to nitpick every little, thing. I'm not looking at like which way your toes are pointed, which, toeing in, toeing out, all that stuff gets
Sure.
really
Sure,
fancy.
sure,
I'm not
sure.
about that. But all the therapists out there, I'm sure will disagree and they like to look at that. And good for them. Um, but so anyway, so they sit down and my first question is, what brings you in today, right? I mean, I don't care if the prescription says back pain. I want to know what they think brings them in today, right?
Mm-hmm.
So um they come in, what's going on, and they tell me, and I go, how long is it going on for? So I need a timeline, right? The
Right.
ones that are injured, they'll be like, oh yeah, I shoveled snow yesterday and it hurt a lot,
Those
right?
are those are easy ones,
Boom.
man.
Now you know what's
When it's
up, right?
acute, those are easy. Those are nice.
The ones
The
that go,
sooner
yeah, the sooner
sooner
the
you get
better.
in, the better you get.
The ones that go, oh man, I had this recurring problem 5 years ago. I'm sitting there going, no, please don't. I'm like,
Man,
please, no. And so that, because then I got to dig deeper. I'm like, okay, so what happened 5 years ago? And most often than not, they go, I don't know. I don't remember. It's been so long, right? Or I go, have you had any previous therapy? And they go, um, yeah, I did physio for my shoulder. I'm like, have you had it for the back, right? And then
right.
they're like, well, I went to overseas and this guy did something, and
Yeah, here and there.
those are hard. Those are hard. But if
Yeah,
they're
those
clear
are hard.
cut, yeah. So in your case, I'm just gonna ask them what happened. Was there
Mhm.
any injury? I always ask if there was any injury.
Right.
If there was no injury, I'm 99% ruling out disc bulge. That's just me. Or disarrangement. That's just me. If there's no actual causal relationship to have someone, now granted, if they're sitting for so long, we know how sitting is bad and it can lead to disc pressures.
Right. That's
But
the highest level of dish
that's
pressures,
just
actually,
me.
when you're
Yeah,
sitting down
pretty
slouched.
much. So that's just me. I just don't see someone sitting like this slouch for like 8 hours a day. Like, I feel like at some point they'll feel the pain, but I
It's a
could be wrong.
possibility. I mean, so okay, so let's talk about like
Hold
these
on.
diagnoses, man. Honestly, I hate them. I'll be honest with you. I hate them. I hate when a patient comes in here in the office and they're like, I had imaging done and I have a bulging disc. I hate that.
And
Because
we
what
already
does
had a
that
segment on that,
what
right?
does that yeah, what does that mean? Yeah, they just think of bulging disc and then they get fixed on it. So what I like to do, I do my little exam and I find a directional preference if there's one. And then I'm like, listen, you have back pain. That's okay. That's normal. Like, people have back pain. This is, doing this motion hurts you. So we're just going to avoid this motion and we're going to work on this other motion for a little bit. And then we can go back to the other motion.
The only
And
thing with the directional preference, I think it works great. There's only one instance where I feel like it kind of doesn't in a way, is where like if how like so when you have disc bulge, right? You have a narrow canal, right?
yeah,
Unless that disc bulge is massive, right? Flexion is generally going to feel better
100%.
because
I mean,
because you're
so better,
no,
yeah,
yeah,
better.
better short term, right?
Yeah, because you're putting pressure
So
away.
so knowing that when you do your assessment and they go, oh yeah, flexion feels better.
No, that's why I don't look at their pain. I mean,
Yeah,
I keep the pain in the back of my mind, but what I'm looking for is that centralization, baby.
yeah,
You
and
know, is that pain going away from your legs and towards your back? Does you can do graded, you can grade your directional preference. I'm not saying to automatically go into full
yeah.
extension right
Oh,
away.
you're good flexion. All right, bend all the way down. Keep going
Bend
for
all
10
the
more reps.
way.
They come
Yeah.
in next day and they go, oh yeah, my leg's tingling.
Uh-huh. And
um,
and and that's another sign, when you see people hunched over and you ask them like, why are you hunched over? Like, because it feels good and hurts to extend, but I'm getting pain all the way down to my toes. Like, that's not a good sign. Like,
but yeah, no,
and
yeah,
then the hard part, the tricky part is payment is convincing them to go into extension. Let's say they are an extension preference. The tricky part is telling them to go extension because they're like, it hurts when I extend, and it feels better when I bend. Like, why would I go backwards? And
Oh,
I'm
that's
like,
not tricky at all. I
and
take a
then you just
picture of them. I take their picture with their consent. I show it to them. I'm gonna go, is this what you want to look like for
yeah.
the rest of your life, right?
And or what I say was like, listen, you've been bending backwards since this pain started. Has it gotten any better? And they'll be like, no. And then I'm like, all right, so let's try this. And then, they
It's
finally are
obviously
like,
another way. Yeah.
yeah. You just
But in,
gotta,
in, in your case though, the 35-year-old, right? Or
uh-huh.
whatever, mid 30s. Like you know, let's assume there was no mechanism of injury. Or maybe
Uh-huh.
they said they went for a run, right? I had this one already. She went for a run and started back up running again and had pain on the right side, right? This is really common actually. I see a lot, right? Just above the iliac crest, not above, sorry, around the PSIS area. And this one
Okay.
always gets me, not gonna lie. For all the PTs out there, if they want to offer advice, go for it. Pain around the PSIS area on the right.
Okay.
You kind of feel it with flexion, kind of feel it with extension, kind of feel it left side bending. You don't really feel it the right side bending. And then it's just like, it's not always cookie cutter. And yeah, that's what you're like, okay.
Yeah, I know. Yeah. And that's when it's tricky. And that's when it's kind of fun because you get to like mess around
So
and figure out what's going
cases
on.
like that though, I ignore the assessments, and when I try to think about like their history, like what they just told me, how they were like running and stuff. Maybe we can look at like maybe they're overarching their back when they're running, right? Maybe they have an anterior pelvic tilt
Lordosis.
causing a facet,
Yeah, facet dysfunction, something like
or
that.
or
Yeah.
maybe the soft tissue in that area is rubbing just because of the fact that you're really arch, right?
Yeah.
Or well, in those cases, I think more like muscular, right? So
And that's when physical therapy gets so fun. When it's not cookie cutter and you got to figure it out. And honestly, guys, physical therapy is so easy. It's so easy.
I think so.
What hurts? Okay, don't do that for a little bit. Oh, this makes you better. Let's just keep doing that. Like what's weak? Okay, work on it. And it's
What's weak? Let's strengthen it. Let's strengthen within pain-free motion. Let's strengthen the other muscles around the supporting structure.
Oh my god,
that's all it is.
It's so people make it so complicated. They do a million things, but at the end of the day, I can't move this one thing in this direction. Well, can you move it a little bit? Yeah. So move it a little bit. Let's work on that.
I mean, I know we're talking about back pain. Sorry to cut you off, but like I had like his full tear of the shoulder. He's going for surgery, but nonetheless, he's still doing PT before. This is obviously a full tear, and he can only get to like here, right?
Okay.
But funny enough, when we do like active assisted, I'm like helping him, and I can get him all the way, obviously, right?
Right.
But it doesn't hurt, right? He can do it.
Yeah. So, full tear of the rotator cuff.
You still work through like what you can.
Absolutely.
And you respect the body's healing timelines. That's all there is to it.
That in a nutshell. That is. Say that again. Say that again for people in the back, Payman. Say that last part.
Like respect the body's healing times.
Yes, respect the body's healing
Don't you have
time.
a chart with that? You have a chart, right?
I've got
a while back.
Yeah, I've got many charts. On typical tissue healing, what is the typical time of muscle healing or ligament healing or bone healing? Yeah, and I like to keep that around just because.
And then the inflammation process, like within the first few days, and then it's like proliferation for 14 days.
Exactly, and I love that because it gives me an idea of like how aggressive to be, depending on where we are in that healing phase, right? Because you don't need to be going, all out in the beginning because they're just gonna hurt, and that's not fun for them. They're not gonna want to do it.
Control the pain. This is my. They come in, control the pain. Give them a few pain-free exercises they can do.
Absolutely.
They come in next time. They generally say they feel pretty good, for the most part, 95%. And then you're like, okay, so let's see if you can go further. And generally, they get more range of motion, right?
Because and the main reason is because
respect the body's healing time.
The healing process is continuing, and time heals.
And what we do is we maintain their motion, right? And we accelerate. Essentially, we don't like super speed the healing time, right? You still respect the healing times,
right? But there are things that we can do to help
But the movement increases
quicken
blood
it.
flow. Blood flow leads to like obviously nutrients and so on and so forth, right, etc. And they're still able to maintain their motion, so it's not like they lead to all this like stiffness, etc. That's why casting sucks, right? When someone's casting,
Yeah.
atrophy,
Yeah.
boom, right? In 6 weeks, you see the muscle difference.
Yo, have you done any research in blood flow restriction?
No.
Oh man, it is fantastic. Oh, I highly recommend it. It is so good. There's research done where there's a guy, they casted their participants in a upper extremity cast above the elbow, so of course they can't move anything, and they did blood flow restriction, and there was minimal atrophy after six weeks. It was crazy,
Really, eh?
crazy.
Yeah. So, but anyways, we kind of strayed away. So back pain. Anyways.
Back pain, yeah.
Back pain. Yeah.
So, yeah, when it's a
stenosis, disc derangement, facet dysfunction, muscle strain. Young people, generally speaking, unless there's like a crazy like mechanism, you rule out stenosis for the most part. Like really,
You have
really young.
stenosis?
No, you don't. You rule it out.
Okay, I was like,
Yeah, no.
wait,
You rule
what?
it out, right?
Yes. Okay. Agreed.
Middle
I was
age,
about to fight you.
middle age, like 35, 40, 50s. They're out there shoveling snow, doing their crazy deadlifts and all that shenanigans. And they know when they hurt, right? They go
Yeah, they
boom,
know.
right? It's sharp pain.
Boom.
It's a
Pop.
sharp pain. I did that one time. And you know, reaching for a glove box, you feel that it's a weird sensation. This is the one pain, like unless you experienced it, it's hard to describe.
Yeah.
It feels like an electrical type sensation. It's really weird.
That's a disc bulge or disc pathology,
right?
And radiating pain. That's all.
Facet dysfunction. Again, you're doing your assessment. They go to bend down. You see deviation from side to side.
Mm-hmm.
They may say, "Oh, I feel like I can't really reach any further on the right side. It feels like locked or something like that." Right?
Mm-hmm.
Whatever their description is.
And the pain for facet is more localized.
Yeah, it's super localized. Like almost like a needle, like literally a pinpoint needle. Like it's localized.
I don't know if it's that localized.
For me, it is. Like, for example, my neck, right? I was doing heavy weights in the morning. I woke up and I turned and I was like, oh man.
There's a facet. Ooh, that's tight. Yeah.
I knew.
Yeah.
Of course, I can't do joint mobs on myself. So I'm like, frick this. Turn payment. Turn the head, buddy. And I'm good to that.
You could use a towel.
You could use a
self mob, yeah. But yeah, it's not the same compared to when somebody else does it. I agree 100%.
It's not the
100%.
Same. So that's how I'd go about doing things. But you know what the most tricky thing with back pain is, though? I'm sorry, but
tell me.
Foreign speakers, good luck. I have so many. It's so hard to figure out what pain and stretch are.
Okay.
It's impossible because everything hurts on them. Like you go, pain's radiating down. But then I do just a general hamstring stretch just because, and they say it's the same pain, and that's the hard part for me. That's my major difficulty. If you were to come in and see me as a patient, I would know what's wrong with you right away, right? Because you're describing things. Right. So the difficult thing for me is the patients describing like their
pain can be hard to describe.
It's so hard. It is so hard, and I'm still not good at like understanding it from their perspective.
And another difficulty is like somebody that has like they've never worked out before, like some of the elder population, you see this a lot.
Oh, not just elderly, dude.
But even younger. Yeah,
even younger. Like they come to me. Yeah,
if they've never worked out, but they describe pain, and then you're listening to them, and then you're just like, oh, that's muscle soreness.
Dude, yes, I had that today.
And they just don't know how to differentiate between like true, actual like. And I'm not saying muscle soreness isn't pain because everybody knows DOMS is painful.
It hurts. It hurts.
But it's not. It's a different kind of.
I think you and I, when we talk about pain, we're looking for that sharp pain. We're looking for something that's inhibiting function.
Yes, inhibiting function. But DOMS can inhibit function too because you get that tightness. You get.
I mean, I worked out 2 days ago. I have DOMS in my arms. I still have to work in my.
For example, man, you go into the gym, have a hard leg day. Tell me going up those stairs that DOMS isn't inhibiting that function.
No, I'm still going up the stairs. It just hurts. Right?
Yeah, but it hurts. It's inhibiting your function.
Yeah. I seriously. So I take it back just because like I did plyo. And my calves were shot, and I was literally walking like a duck because I didn't want to like, toe off, right, or push off. I kid you not. People are like, "What are you doing, Payman?" I'm like, "Dude, you don't want to know. I can't. It hurts." Yeah, never mind. I take it back. You're right. It could DOMS could definitely inhibit function.
But yeah, that's when it, it gets hard, and you really have to kind of pay attention and listen to the way they're describing pain. And then of course there's emotional pain, and that's a whole different story.
I could talk about that. I've had
I
post
think we
COVID.
did talk about
I
it.
had post COVID cases, eh? Like I've had post COVID cases where they come to me and these guys are like bawling, right? You know, they're just like they're shook.
Sure.
They're shook. So it's a real thing, for sure. But.
Oh, for sure. But so I've seen a lot of videos on YouTube about different people getting some sort of treatment, and it's like an emotional pain, and I'm like, man, this is some good like marketing. Like this is like people love to watch it, like when you give a crack and then like they start crying, and that's it's good for the views.
So how do you like, I mean, you've been in the SNF or skilled nursing facility for a while.
Yeah, I'm back in a nursing facility.
Let's assume that you're not in this SNF. How what do you like to do for back pain? What are some of the things like you like to do? Maybe the folks watching this podcast can be like, oh, my PT does that. That's pretty cool. Oh, my PT hasn't tried that. Maybe we could.
So some typical stuff, regardless. Okay, so let's talk about like somebody with stenosis or something. What I like to do is gentle things, pain-free, that promote movement.
Lateral trunk rotations.
That's it, baby. LTRs, or I call them lower trunk rotations.
Yeah,
lower trunk,
call them.
Posterior pelvic tilts.
Great.
Classics. Because what does it do? And people are like, oh, those are so basic. Yes, they're basic, but they work. Why? Because they promote motion in a pain-free range of motion.
And lateral trunk rotations, or what you call lower trunk rotations? Whatever.
Lower trunk rotations, yeah.
Either way, you can control the extent of the rotation, right?
Exactly.
Easy.
And then what does it do when there's more range of motion? You're getting more blood flow.
But not just that, it gives them confidence, right? When people are in so much pain.
Yes, that's it, Payman. That is exactly why I do it. It gives them confidence to move.
This is good. There's no issues. It gives them confidence that I can do something. Dude, I have people, listen, so old people, geriatric, I gotta stop saying old, geriatric population, they come in, right? And then, dude, she was crying because she's never had an injury. Independent of their active daily living,
right?
All of a sudden they get back pain and they're no longer independent, right? And that hurts. So the fact that you can show them they can do something pain-free, like, whoa, I can do that, right?
That's the thing. So many people, understandably, like when they're in pain, they're afraid to move. And it's not just geriatric population, even the younger folks, even like, if you're in pain, they're like, oh shoot, if I move, like, and you can see in their eyes, like when you tell them to do something, they're like, that's gonna hurt. But if you show them, like, hey, like not everything you do is gonna cause you pain, and look, we can find movement where it won't hurt you.
Yeah, and right away they're like, oh, okay, so now I have some control over my body, promoting independence, which is great, right?
Which is important. Oh, I'm so glad you mentioned that, because yes.
So anyways, so PT, again, we went to talk about how PT doesn't have to be complicated. You don't need to go to a therapist that makes you do handstands and backflips and heals you, whatever. Right? I just
keep it simple, stupid.
That's my thing. Again, it's just the way I treat people, like patients.
Right.
I hate patients too. Clients, whatever you want to call them, right? Simple. They're injured, promote movement that, like you said, is pain-free.
Yeah, give them confidence. Show them that like they are in charge of, like they are capable of way more than they think they are.
So LTRs, posterior pelvic tilts. Again, LTRs, you're not going to mess up anything, right? There's no way. Posterior pelvic tilts, you're not going to mess up anything. Right.
And guys, we're not asking to go all the way to end range. We're not saying, with your lower. So if for those that don't know what our lower trunk rotations are, it's when you're laying on your back, you have your knees bent in hook lie position, but your knees bent, and then you just swerve your knees side to side
a little bit,
side to side. Now we're not saying, go all the way to the side so your legs are touching the table. Like if you can do that pain-free, fantastic.
Which I usually say, if you're able to gradually build up to it, go for it. You know what I mean? Like in the beginning, even though you're going this much, as they get more comfortable with the motion, I have no issues with them going further. Like, what I mean?
Absolutely. But that first visit, maybe they can only go literally 2 inches.
You know what I do, Nico?
What do you do?
I don't even go, okay, get on there and just go side to side. I put my hands on them just to comfort.
And you move
And
the
I
knees.
move the knees
I
gently.
do that
Yeah,
too.
like very gentle. And then I go, okay, how's that feel? And they go, oh, that's not too bad. Then I go,
Because
okay.
at first they're all tense. They're
Yeah.
like, what are you about to do?
So then I'm like, okay, you want to give it a shot? They go, yeah, sure. They do it. I'm like, oh, that wasn't so bad, right?
Oh.
But just your hands on them, just to kind of get
Oh,
them going, is
absolutely.
again, it sounds simple, and maybe you don't need a doctorate degree to do that, but why complicate things, right?
Physical therapy is easy.
Yeah,
I mean,
posterior pelvic tilts, but
I mean, so yeah, those are basics, man. And then of course, like if they've got a disc,
we can get a little bit more specific. Like I like to do
yeah,
like glute bridges. I like to do prone press ups. Like
I don't, and for homework, I just, you know what I tell them? Lay down, face down.
Oh,
And
you
then
just
I'm
get
like,
them on the, yeah. I
and
guess
I'm
it
like,
depends.
and then I'm like, if it hurts, put a pillow under your stomach, and then just
Yeah, the
literally,
McKenzie progression, yeah.
and literally just hang out there. And they're like, that's it. That's all I have to do. I'm like, yeah, for now, that's all I want you to do. And then they come back and they're like, oh wow, like I feel a little bit better. Like all I did was lay down on my stomach. I'm like, yeah, see.
Depending on the acuity, like for example, like when someone comes in, I generally like if I can get them. I personally am a little more aggressive, so if I can get them to do like a glute bridge, even like a quarter or like half,
Right.
I get them going just because I'm like a super believer in like glute max strengthening. But
oh, the glute max is weak on everybody.
We're sitting on our butts all day, right? So
I know it's an
anyways,
inhibitory technique. That deep pressure on the glute is an inhibitory technique.
So I like to do that. Prone press ups, of course. There's a progression. Prone on elbows, all the way up, right? Whatever.
Right. Oh, dude, best believe, like if they can tolerate it, I am like,
you're like overpressure.
Oh man, I am over pressuring. I have them on their elbows, and typically, in the first visit, I can typically get them at least on their elbows with overpressure, with the sag, with the exhalation.
And of course, the whole time you're asking, like, how are you feeling? How's this feel?
Yeah, and you always make sure that it's centralizing and not what is that other one called?
Peripheralizing. Tongue is always like screwed up with that. I'm not gonna say it.
Peripheralizing.
But and I like to do honestly, I still love joint mobs. I know studies are kind of 50-50, but I like joint mobs.
I love joint mobs, man.
Even doing a basic grade 2, people love it. Feels good,
It should, man. Grades 1 and 2 for pain. It should feel
good. There you go. No, and I honestly, I do what I would do to myself, having had injuries and healed myself. But I like doing joint mobs. I love bird dog. It's become my favorite exercise of all time.
Bird dog.
Cat and camel has cat and cow.
I love me some cat camel.
Has come up there.
Especially for those facets. Oh my gosh.
Even stenosis is okay.
Cat camel. I'll do the is it the cat part or the camel part? I do the cat if it's stenosis. I get them on
the camel where you're humped over.
The camel was the hump. Yeah. I always that. So, dude, I've also heard cat cow.
Yeah, I know. I don't even know how. To be honest, my client was like, "Who comes up with these names?"
I don't know. So
bird dog, I love doing. Then if they can tolerate bird dog, and eventually, I actually like really doing dead bugs now. Like still, like while maintaining a posterior pelvic tilt. Trying to dead bug. But
because it just activates your core better.
Yeah, and
I love that PPT.
And core strengthening is obviously super important for low back pain, right?
Why?
Well, honestly, this is how I explain it to my patients. I'm sure PTs out there are gonna slap me in the face for this.
Let them slap you.
Don't care.
Come at us, baby.
So if you're not strong in your proximal section or your core section, right? You're not stable. You can't be stable distally. That's just basic physics, right?
Explain.
So if you're stable at your core, it's easy to reach out and do whatever you want.
I agree.
If you're jiggly here, you look like a little like right.
You need a good foundation. You need a good strong foundation, and it starts in the core. 100%.
So if you're building your tower and your base is not strong,
exactly,
that tower falling apart like Jenga.
Can you do that dance again, Faven? That little.
So that's
in those car commercials.
So that's why bird dog again, core is working, bridging. You got core activation with glute activation, right?
Love me.
Posterior pelvic tilts. You got some core activation. If you want to do TA, I don't really do it because it just takes too long to explain to patients.
I don't do TAs.
But do TA. There's nothing wrong with it.
So how do you explain core bracing to people?
Oh, this is how. Okay, so I say push air out through your core instead of sucking it in. I don't know how you want to talk about it, but you know how people like push their tummy in.
Uh-huh.
I like to say push it out, like as if you're pushing air out through it. That's how I explain
It's
bracing.
not bad.
Or
You know what I like to
you gonna
do?
say the
What I
toilet example when you go to the bathroom.
No,
Okay.
nope. I like to tell people, depending on their age and my relationship with them, I say pretend that somebody is either about to tickle you or punch you in the gut. What do you do?
I like the tickling one
Yeah, but you know, obviously, I'm not gonna tell a
because
90-year-old.
Punching might be like sucking in your belly.
But
That's what people
obviously,
think
I'm
of.
not gonna tell my 90-year-old patient pretend that I'm about to punch you in the stomach.
Or
What do you
tickle
do?
you.
Yeah, I'll say pretend I'm about to tickle you. Or
Yeah.
what are you gonna do?
Yeah.
And then what does your core do? It instinctively braces. That's how
It braces. It doesn't suck in, right? It
right. It
pushes out.
braces.
It braces.
Exactly.
It's almost like a Valsalva in a way, if you really think about it.
Yeah.
In a way, right? Another thing I do is like put the tongue on the roof of your mouth, right? And then brace. So that kind of helps. If you
Oh,
like,
I've never. What is that tongue in the mouth?
I don't
Roof of the
know.
mouth
It
do?
just helps. And if you like kind of hold your breath and you're doing heavy squats. Anyways. Um
I love how you just brushed over. Anyways.
even for a TA, they're like, how do I activate? I go, well,
Man.
try to hold your pee in, right? I mean,
Uh,
I don't know how else to say it, but
yeah, I like the imagine that you're about to get punched or tickled, and then
yeah,
everybody,
I like the tickling one.
yeah, everybody. Obviously, I'm not gonna tell if it's a younger person, like of the opposite sex. I'm not gonna say like imagine I'm about to tickle you because
No,
that
you keep the door open first of all,
Oh,
and
absolutely.
yeah,
But yeah,
yeah.
you
We can
just kind
talk
of
about all that stuff later, but
you
yeah,
just gotta kind of pay attention
protect
to who your
yourselves and
patient
be
is.
safe. Exactly, and watch out what you say.
Yeah.
We're very friendly with our. I'm very friendly, so
Oh,
I'm
I
sure
am
I say things
super
I
friendly.
probably shouldn't say, but
I get away with it.
everything is professional. Obviously, at the end of the day,
Yeah.
yeah.
Absolutely. Yeah.
So yeah, core strengthening, we talked about blah blah blah. So stenosis, now we're getting a little more specific. So for stenosis, I actually have hands-on techniques, right? You can get them in side
Oh.
lying, and you can actually block a segment off to do some opening.
Yep.
You can get them in child pose and block a certain spinal segment, and then apply pressure to try to get an opening in that spinal segment. You can do your
Yep.
facet gapping if you really want to.
So really, what you're doing is
Opening up the
opening.
space. Yeah.
Yeah, you open up the space. So you're
But
you're
again,
putting the
yeah.
lumbar flexion.
Joint mobs, again, feel great at the time. They're not long lasting. We know this. So I use them as I personally use them as a precursor for exercise, to be honest.
So
Don't tell me joint mobs are long lasting. I will slap you through the monitor.
No, I agree with you 100%. So you're telling me, Payman, that you disagree that you should only mobilize do joint mobs?
Yeah, man.
Yeah, no, I agree
I
completely.
mean, I don't know if that's a trick question.
I don't know though, because I know some people that so there's a huge debate in the PT world right now.
Because PT is not black and white, it's gray all around.
And there's anti manual therapy. There's exercise only therapists.
Hashtag Reddit.
There's all these different types of things. So my way of thinking and my reasoning on why I consider myself a manual therapist and why I will continue to do manual therapy is because I do manual therapy because acutely, yes, you will get motion.
You get motion, you reduce pain levels.
Yeah,
For sure.
absolutely, hands down. But will it stay? Absolutely not. It will not stay. So that's when I do exercises.
Why I want to
after
stay?
that.
Because true adaptation takes time, right? And
Yes.
true adaptation requires controlled progressive overload, which is done through exercise.
exercise. So if there is a somebody, a practitioner that only does manual therapy, that only cracks your back or whatever,
I'm sure it feels
and
good.
without any exercises, are they doing you a disservice? My answer is yes. It feels great, but again, you're not getting that independence. You're getting that you're relying on the therapist, and it's just like it's not ideal. Now, if you have a therapist that only does exercises, are you going to get better? Sure, absolutely.
Honestly, I think that's not a bad thing either, to be honest.
Yeah, I'm not saying it's a bad thing either, but I think the combination, and research shows that the combination of manual therapy and exercise gets the best results.
Right? Using manual therapy to promote pain-free exercise or to
Right.
enable the motion to perform the exercise.
Exactly. And that's why I do it, because with the manual therapy, now I have decreased pain and a little bit more motion. So now I can perform those exercises in an improved range of motion without getting that pain.
Like I
And
know
so
we're
that's
talking
why,
about back pain, but I had a case with post what's the surgery where they like fold the ligament over one another in the shoulder to prevent like to improve shoulder stability. They like stitch it up, I think.
are you talking about the capsule? Like
Capsule tightening, a capsule tightening procedure. I forget what the actual name
right.
for it is.
Which
No, never mind. Did they do a capsular release? They did something for a frozen shoulder. I think it was capsular release.
it's got to be released then.
Yeah, yeah. And anyways, the patient obviously lacked motion, right? And you best bet I was doing my grade 3s and 2s and whatever, right?
Right.
In the order to try to promote the motion.
Sure.
But I would always follow it up with like a specific exercise.
Always.
Like if I'm doing like, glides like downwards, I'm trying to promote like abduction.
And flexion.
You best believe they're going up on the wall, maybe possibly doing wall slides or ladder climbs or whatever, right?
And honestly, I think that's what the ideal, that's what a good therapist should do, or a good practitioner really, use a combination of both. I'm not a fan of like, oh, I'm so against this, I'm so against that, because
that's silly.
There's
That's
a reason.
silly.
There's a reason for it.
So it's funny because we talk about this because I had a patient who loves soft tissue, right?
Oh, soft tissue.
She loves soft tissue.
I'm against soft tissue. I'm just kidding. I'm not against soft tissue.
I did. I think there's nothing wrong with it. I mean,
right.
I do Graston on myself because it
right.
Graston spawn. Actually, no, I'm with Hawk Grips. Never mind.
I'm with Hawk Grips.
But I have their tools, right? So she was feeling better, but she hated exercise, right?
Mm-hmm.
She started exercising. She was noticing she was getting much better than before, right?
Oh,
Initially, she's asking for that IFC, right? For 15 minutes. Now we go in and she's asking to do burpees. Like, what do burpees have to do with neck pain, right? It's just wild, right? So this was the one where I was like, oh man, she's not gonna get better because she hates doing exercises. She doesn't do them at home, but now she just she loves it. So sometimes like if you get a patient that doesn't want to move because they're scared to, stick with them. I was wrong with this one, so
stick with.
You may be
and
wrong.
that's when you can use things like soft tissue and stuff when they have that when they'd rather have that passive stuff. You can kind of, I'm not saying trick the patient by using passive modalities, but get them to warm up and gain confidence in themselves.
Yeah,
with those modalities.
So we talked about low back pain, right? For example, I like to work on the paraspinals. I like to get in that multifidus gutter area. I like we talked about, I like to do my joint mobs, right? So I still like to, because even with the pain, right? Even though you may not see it, those muscles may be kind of guarded, right?
Yeah, absolutely.
And just doing soft tissue of the lower back, even, it helps them relax. Doing IFC with heat, short term, it's going to help them relax. Now, all of a sudden they're relaxed. I go, okay, now let's try a couple of these exercises, right?
Let's do some stuff.
And because they feel better, they're good to do it, right? And then they do that. So you could say I'm tricking them, whatever. But at the end of the day, whatever gets the patient moving is our ultimate goal. So
that's true. And yeah, and personally, I just don't use modalities, just because I can get what I want from like a manual kind of therapy. So I don't. And in my opinion, I can get a little bit more specific with manual therapy than I can with like a TENS unit, which feels fantastic, by the way. But it's just a personal preference.
I mean, there has been times when like, listen, it's hard to, it's weird because people, like I said, don't want to exercise. It's just when they're in pain. So there have been times when I've used the IFC before, and there were times when I was like, you know what, let's try these. And I know it's pain-free. We're doing all these pain-free exercises. And then I give them just the IFC as the candy, right?
Yeah. And this is just the beginning. Payman, you actually talked about, which I'm really glad that you do it. And I know not everybody does it, but we had a conversation the other day, and you were talking about how you grade your soft tissue stuff. Can you talk about that?
Like, what do you mean grade? Like phases? Oh yeah. Like, well, I do with the Hawk Ribs, like the instrument assisted soft tissue massage, or even with the hands, you can do whatever you want. I like to start with. I just like to start with passive. So that's basically the tissues on this resting position. You're just working the tissue with whatever
Patient just
tool you're
relaxed.
using, whether your
Patient's just
hands. Yeah,
relaxing.
you're just working on them. You could compare it to massage therapy at that point. Well, not really, because they do other. Never
They
mind.
do other stuff.
Ignore that part. You're just working on passively. They're not doing anything. And then I like to, as they're starting to feel better, right? We could say they're moving away from that acute phase, right? I like to kind of put the tissue on stretch and do my soft tissue techniques.
Okay,
So
so you,
now,
you put them in a lengthened position.
yeah. So let's say I'm working on the calves, right? I'll get them to dorsiflexion and prone, and now all of a sudden I'm working on them as is, right?
Okay.
And then I can even do things like taking them from like slacked position and then doing soft tissue as we're lengthening, right?
Oh, okay.
And then I go, okay, now do your ankle pumps, and I'm working into the muscle, right?
Right. So now you
So
get.
I just have like this graded approach to it. It works great. I had a patient with like
And I can appreciate that, and I might include that into my treatment and see how that works, because I appreciate that.
it's a bit more intense when they're again ankle pumps, and now let's say like rhomboids, for example. Now they're doing weights, and you're using your hop grips tool and trying to work into it. Now you're getting the combination of exercise and soft tissue almost all in one, right?
Yeah, and I know therapists also do that with like with cupping too. You know, they'll cup you in a static position when you're just laying down. They'll cup your back or whatever, and then
Which I'm not,
maybe
yeah.
next visit or whatever, they'll cup you while you're moving, while you're doing a stretch, while you're doing like, let's say,
Yeah, like you can have cups placed on you, like on your quads, for example. You're doing knee extensions, right?
exactly, or
Something like
on your
that.
back, and you're doing like you're on all fours and threading the needle,
Yeah.
so stuff like that, which I appreciate that. I
So,
like that.
now we were kind of, I don't know, what are we doing with time?
We should end soon.
Just to kind of briefly touch up on, sorry for the lengthy podcast, but just to touch up on when you look at back pain, and I should probably do this more often, looking at the below the joint and above the joint scenario, looking at the feet and the hips and stuff. Honestly, I'm maybe not the best at doing that. This, I don't know why, but
real quick, Bayman, are you telling me if I have back pain,
it
it
could
could be
come
because
from
of
your
my feet?
hips. Yeah,
It can come from my feet?
Yeah, it can. It
Why?
can. Don't do this, man.
let's say Payman, let's say that I am flat-footed, arches. The only arches in my life is McDonald's.
Man, but why are you flat-footed? Were you born like that, or you?
Yeah, let's say
Let's just
I
say
am
you're
just
flat-footed and you have
flat-footed.
externally rotated tibia with an internal rotated femur. You got some valgus going at the knees, and you go to squat and it looks ugly because you squat ugly. Now your back hurts.
But yeah, guys, that's so that your body is a whole chain, right? So you have to look at the whole picture. You shouldn't just focus on the back. Look at other places. Make sure that your knees, the motion, start somewhere. It can literally be anywhere. You can start. I like to start at the feet. Make sure that's like all the motion and everything is correct there. Then
That's
move,
getting very
break
nitpicky
your
though.
break it.
So like
Right.
it's almost like the reason why I don't do it is sometimes I feel like I'm forcing it. I'm formulating it. Like, and I don't like to. I'm
Yeah, and
looking for it. I
it's
don't
not
like
and
to
it's
do
not with
that.
everybody. It's not with
Yeah.
everybody. It's with certain, when you are like, oh, like you can tell like, ooh, that valgus in their knee is ridiculous. Like it's the ones that pop out at you.
Like I'm sure
Because
there's somebody out there that's gonna say that the latissimus dorsi and the tightness of it, or there's a whole. I don't know if you know the lines of the back, right? Like the paraspinals to the glutes, your glute weakness is causing your low back pain. So I check the hip strength. I know
right.
that I check it. Okay, I check it. But if it's like I'm applying pressure and they're strong on the hips, I don't go, okay, your hips are weak, right? I don't make it happen. They're strong. So why are they still hurting, right? So
Right. You want to just make sure, like,
I like to be
things.
unbiased. I hate, man. I catch myself doing that sometimes, and I really, I'm not perfect.
But
Where like you try to like oh man, this is like cookie cutter. Like let's say like frozen shoulder, and you're like, oh man, that capsular
easy,
pattern.
easy.
Or like you're doing the low back and like, this got to be muscle strain, right? And
Right.
then
And then you can do it and like, wait a minute. That's not supposed to happen.
or you know what it is, or you know what it kind of is, and you do all these tests that kind of keep confirming it, and you sound really smart doing it, right? Like you think it's a disc bulge, SLR positive, slump positive, and it's just like
Right. Boom, boom, boom.
disc
That
compression
makes you
positive.
feel. Then you're like, oh, this is easy.
But I hate forcing a diagnosis on people, so I won't. I try to keep things simple. But yeah, look at the hip.
Yeah, man. I don't even give patients like a diagnosis. I don't even
You
mention.
know what, lately I wonder if like thoracic mobility leads to back pain. I'm
Huge,
sure it does,
huge, right? Huge. I probably give almost all my patients manipulation of the thoracic spine.
Yeah, it has pretty good.
Of course, unless they're freaking like
yeah.
hypermobile, I'm obviously not gonna manipulate
Hypermobile,
them.
if they're fractured, if they're super old,
Right.
they have osteoporosis. Let's get rid of contraindications, right?
Yeah. Let me just say that real quick
before someone shoots you in the head with that statement, right?
Yes, but if they are appropriate for thoracic manipulation, I give them thoracic manipulation because it
But
is
yeah,
safe,
before
it's
we
easy, it feels great.
long story short, if you have back pain and as a patient and you're visiting a therapist, just understand that movement is good.
Movement is
Pain-free
good.
movement is good. Your body takes time to heal, so respect the timeline. Do not expect
Love that.
overnight results.
Flip that.
Your therapist may do things differently than us, and it doesn't necessarily mean they're wrong.
Give it time.
Give
Let
it
your
time
body.
to work and let it work. If generally speaking, I would say if you do not see a response within 2 weeks, even marginal differences, probably got to switch things up a little bit. Would you say
Yeah.
that in 2 weeks? I think if they don't see it,
You'll see it. You should see an improvement in 2 weeks.
assuming they do physio once a week at least with their homework.
But typically, I like to say a month. If there's no change in 1 month, something needs to change.
Yeah. So,
but you should feel better with at least a little bit better within 2 weeks.
Yeah, and then the other thing is that I would say to patients is that if you have pain, and you go to your therapist and they say, "How you doing?" You see, so you go, "I still have pain." My follow-up question is it still as intense? Is it the same duration? Is it the same frequency? And more often now they'll say, "Oh yeah, you know what? I didn't really feel it yesterday.
Maybe
I just kind of
a
feel it
little bit
today."
better.
So that's just
And
to
small goals, start off. You want to have more good days and bad days.
yeah,
And eventually, you can work your way to pain free, but just have small, realistic goals for yourself.
My only other comment would be is to just trust in your patient or therapist, or you should really, or you're not going to get better anyway. But trust in your therapist.
Trust in your body.
And it may seem what they're giving you sometimes simple, but there's a reason. So just stick to the plan, right? Stick to the plan. Don't quit on it, and you'll get better. And to the PTs out there, obviously, we kind of talked about what to look for and what to do, and we offer some of our own treatment techniques. Of course, we could be a lot more specific. If you guys want to see more specifically outlined treatment techniques, we could certainly talk about that, right? We could say sciatica, boom, 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 whatever.
Right. So yeah, let us know what you want to listen to in this podcast, because we had a couple of ideas of what to talk about, but we would love
like Nico
input.
and I, we like looking at articles and we do our research, and we're always trying to keep up to date. So we want to offer you guys both a patient perspective and both a physiotherapist perspective on how to best go about treating someone and what the current treatment methods are. That's not to disregard any old methods, right? So if you're still using ultrasound, I'm not going to get mad at you. Nico might, but but yeah, anyways, we good?
Guys, thanks for tuning in. We really appreciate it. If you can give us feedback, we would love that. You can shoot us a DM.
Ask questions, please.
Leave a review.
Please.
Yeah, we kind of lost the questions, so we're starting fresh on that. Leave us a review. Give us 5 stars on where you're listening.
Or 4.5. I'll take 4.5.
I want 5. Even if
I'll take 4.5 just because I was absent for 4 months.
Even if it's a lie, give us 5, and then we'll make it better. We'll make it worth your time. For real though, give us feedback. We love that. Let us know you're listening to us. That way we don't feel like we're just talking to ourselves, which we don't mind, but it's nice.
I don't mind talking to myself. I've been doing it for 4 months since the lockdown. Anyways, I'm not gonna get into that. Okay, guys.
Guys, we appreciate you. We love you. Stay safe.
Later,
Have
guys.
a great day.
Have a good one.